Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that fits in with your busy life. I'm Pat, editor of MIMS Learning, and I'm delighted to bring you a special episode of the podcast recorded in front of a live audience, a first for us. We recorded this episode at MIMS Learning Live South in London, and it takes the form of a panel discussion about obesity, featuring two doctors from Goggledocs, Dr Patrick Holmes and Dr Amar Puttanna. Between them, they know a huge amount about obesity, type 2 diabetes, and cardiovascular renal metabolic medicine, or CVRM. And during this discussion, they were able to share their insights with our audience and answer their questions. I really enjoyed the session, and I hope you will too. So, lovely to have you here today. Thank you very much for coming. Patrick and Amar, would you like to just introduce yourselves a little bit first?
Okay, despite the jacket, I'm a GP, so I wear this jacket so I look like I know something. So I'm based in the northeast of England, was a GP partner for 26 years, then saw the light, and I'm now a portfolio GP, so actually getting a bit of work-life balance in my 50s.
And despite the jacket, I'm a consultant diabetologist. I am a diabetes specialist, but I work in primary and secondary care. I do a lot of work with PCN communities in South Birmingham and work in North Wales at the moment at Wrexham Mailer, and have broad interest in diabetes, cardiovascular disease, and older adults with diabetes. And together with Patrick, also are part of a medical education group, and a group called Goggledocs, which is what we're here for. We do a lot of social media, online digital education, and in-person education. And that's us. And
Goggledocs has lots of sort of education videos and things like that, doesn't it?
So we're on X and we're on YouTube. So we've got about 17,000 followers on YouTube. So nightmare to find us because everybody seems to, as my son pointed out, sounds a bit like Google Docs. So you have to, anyway, search for it, and if you're good at search things, put minus Google Docs, and we pop up quite quickly. But we've got some name recognition issues, but and we're both active on LinkedIn, so it'd be great if you want to connect on LinkedIn.
Thank you. So the first question is a big, wide-ranging question. What is the impact of obesity and associated conditions on patients and on healthcare?
Well, I brought my iPad, mainly because there's big numbers, and I can never remember numbers. But I suppose one thing to think about in terms of the impact on the nation, it's big, 3% of our GDP is lost by the effect of obesity. So if we didn't have obesity, we'd be 3% wealthier. So and what do those big numbers look like? We're talking £126 billion a year it costs. So, and that number has been going up. Of course, there's a lot of different costs within that. The NHS costs are much smaller. So we're talking about just a mere 12.5 billion. And those costs are going up year on year. So one of the challenges as a nation we have from a political perspective, I suppose, is productivity. Sometimes you'll hear about that on the radio. Europe's so unproductive compared to the States. I can't understand. But one of our productive issues, I think it's the States would have the same issue, is obesity, because, as I say, the financial impact of obesity and the diseases that it affects and the time off work and associated morbidity, again, it's that big number, which is £31 billion a year. And those numbers come from the Frontier Economics report of 2025, and the report from 2023 is often quoted by, or was quoted by Wes Streeting.
I guess from my point of view, what's the impact of obesity? Burden, in a way. You say I put in a broad sense because burden, the patient perspective, doesn't have the conditions downstream that obesity impacts, not just the conditions, but also the mobility, the working life issues, the number of associations with obesity now that we're finding, from chronic pain to productivity, etc. impact and burden on the workforce, so ourselves, and how we manage such patients, looking to the future, but managing them now. And that has health and economic burden and political and policy burden. So that's what we're dealing with, and it's clear, and you can correct me and you can challenge if you feel otherwise, that we aren't ready, and we haven't been ready for it, despite knowing what's happening. We knew, I always say follow, in a way, in UK we follow America in a lot of things, certainly healthcare is one of those things. If you look about 20 years ago, maybe 15 years ago, it was when Texas is the fattest state, or the most obese state, correct word, in the US, and 1 in 4 people were obese or overweight. Well, now we're in the UK, and we look at the data, about was it 40% of people are overweight or obese, so we're there as well. So we've seen this coming. We've seen this in type 2 diabetes, we've seen this now in obesity, and yet we haven't exactly quantified how to approach it. And this is where we'll talk about it over the course of this next half an hour or so, about the rollout of incretins and the rollout of diet and lifestyle changes and modifications. We're playing catch up, and also we're fighting consumerist healthcare as well, and consumerism, which again is an interesting thing that I've not really seen before as such, and largely driven by medication is the honest answer. This is all driven by incretins. When we saw this about a few years ago, when on the Oscars they mentioned about Ozempic, I was like, we've arrived where now what we wanted patient engagement. We wanted buy-in to say, well, actually we want to improve our health. Well, the reasons for them going on weight loss medications may vary, but we've got buy-in, but how have we approached that? How have we utilized that? I don't think we have, and I think we've created a two-tier system.
I'll correct you on one thing. Amar said it was 40%. It's over 60%. So the average BMI in the country is 28 now. 28%, nice and easy to remember because it's the same as the BMI, is actually with a BMI above 30. And again, I'm looking at the figures. Public Health England, this comes from, is 36% in the overweight category, BMI between 25 and 30. So it is prevalent, and we all know the diseases. So we, type 2 diabetes, Pip's going to be doing a session on that later on. I'm looking forward to. Cardiovascular disease, sleep apnea, cancers. The number keeps on going up. One thing I've quoted is 13 cancers. I think the number's actually far higher than that. So it has a wide hypertension, cardiovascular disease, kidney disease. So the impact is huge. I mean, it is the modern epidemic in that sense.
Yes. Pardon me.
And yet, just briefly,
Yep.
It's not classified as a disease in this country.
Yeah, that's an interesting point. And if we look, as Chris Whitty has been saying lately, if you look just across the channel to France, the picture is completely different there. And so, why is that is a good question. So, obviously, you've set the scene. How are non-pharmacological measures working to address obesity in terms of public health measures? And have we gone far enough? What else should be happening there?
Yeah, so I arrived early today. My daughter's moving into her first home, so I hadn't got a card. And it's today, so I'll see her later on, but I've got a card. But I got off at West Brompton tube station. A lot of you will have done. So there's the old Brompton Cemetery is just there, if you look on the map. And in pride of place in there is Dr. John Snow's grave. So presumably you all know who he is. Not the guy from Game of Thrones. That's a different Jon Snow.
Something.
But yeah, so he's the public health doctor, well, the doctor who essentially is the founder of public health, and he identified cholera cases by looking at a map and seeing it seemed to come from people drinking water in one particular pump on Broad Street in Soho. So, and we are today. So what would Jon Snow think of all of this? And I don't know if he'd necessarily advocate widespread use of GLP-1s, if I'm being honest. Certainly a lot of the public health consultants would say that's perhaps not the best way to look at it. And I think that's an interesting perspective maybe we can come back to. But I think if we look at what does work, think some public health measures do work. So the sugar industry, sugar drinks industry levy worked. Reduced, or rather improved quality of life years by a factor of about 30,000, between 20 and 30,000 life years to our children. So as a nation, so it's added quality life years, and it helped stem some of the weight gain within certain groups, particularly actually in deprived communities. There are other things which have shown promise, but have not been rolled out. And the sugar industry, globally, to say, it doesn't just work in this country, it works in countries like Mexico, etc. And that is actually if you move hot food, takeaway is the word, I think, convenience food, away from schools. That seems to work, okay? And if you limit the number of hours these hot food, convenience food, junk food, I suppose, work, that also improves matters. But I'm not seeing much going on that. And I'll do, and I'm full of random facts, as you've probably already worked out. So this is all politics, of course. And I'm not a politician. I'm not public health. I'm a GP. So that's what I am. But it's Otto von Bismarck, okay? Probably about a century after Dr. John Snow. So he came up with politics is the art of the deliverable, and or the possible. And I don't think he said it in English, and probably said it a bit more fluently in German, I would imagine. And I think that's one of the challenges. So we do have public health measures, but actually getting them to work. We do know some things don't work. Little evidence for exercise on prescription, sadly.
You can all see why I hang around Patrick. It's good entertainment value. But so yes, we know certain things work. We know that reducing high sugar containing foods in our diet, in our lifestyle, ultra-processed food has its benefits. We've got data suggesting that, epidemiological data showing that, but also we've got practical data. So you said Mexico. Mexico introduced one of the first country to introduce a sugar tax, and they've shown that there's impact on obesity and type 2 diabetes has reduced as a result. Well, linked to that, you could say, but that's shown on a national level. Colombia has introduced a ban on ultra-processed food, or a levy on ultra-processed food. And so there is top-down approaches, and the key thing is this: whilst we all know these things are improving, it does involve, the individual, the person, and include ourselves in that, but also includes the top-down, so the government, the policies, and the structures around that. It includes all the taxation, all the products, all the consumer, all the food products, where they're produced and manufactured. And unless all work hand in hand, we're not going to get there with that. And again, you mentioned certain things like ban advertising after 9 p.m. until after 9 p.m. Childhood obesity is the thing we're looking at and trying to learn more and more that this is, some people say even in the placental environment, or it codes your genetic kind of risk of obesity down the line. So even early on, we know that, and we're seeing in America and also in the UK now, higher incidences and prevalence of childhood obesity, which has its impact. So we need to target across the range of ages, stages of life, but also the different methods from advertising on the tube, advertising on TV, advertising around TV, childhood TV programs, etc. So we've started to change that and do that, but it's an amalgamation of different things. And then you haven't talked about affordability and cost. So we say no ultra-processed food. We say fine, have an avocado, have XYZ, have everything. And these aren't cheap products, and we have to look at across the range of deprivation and range of education range of the country.
And I suppose the fair thing to say within that, these are strategies mainly in public health in preventing obesity rather than necessarily treating the obesity epidemic we have right now.
Yeah. So obviously all the factors that you've talked about, that translate, for everyone in this room, that translates into the person in front of them in this consultation, and they'll be seeing the results of the environment political and sort of consumerist environment that we all live in. And obviously you can't influence everything as a GP, but lately GPs have been encouraged to try and manage cardiovascular, renal and metabolic conditions together, and that's part of the story, isn't it, that's emerging. So what's the potential for benefit there if GPs really take that on board and manage all these things in harmony together?
So there's lots of different answers to that, I suppose. I think an important frame to think about, a lot of these therapies actually are cardiovascular agents that happen to lose weight. So if, for example, if we look at one study, select study, so used highest dose semaglutide, the drop in cardiovascular disease was seen before the weight loss. So I think we need to frame it perhaps in a different way. I think I've seen the impact, I suppose, compared to some of my peers in terms of the benefits to my clinics, because I was a very early adopter of GLP-1s. So instead of giving people insulin, I was giving GLP-1s 12, 13 years ago. And that meant my clinics were a lot quieter and more resilient to the increase in diabetes, because it's a damn sight easier for someone to manage on then it was twice daily incretin, then it was a once daily, now once weekly, than it was, and actually managing their blood pressure became a bit easier, and they were aging a bit better. So, and actually, it's one of the few medicines people actually don't want to stop taking. So it's because they put the weight on. So I've seen that. And then we do know, the governments are keen on things like SGLT2 inhibitors. And I was the world's highest prescriber of SGLT2 inhibitors. I'm a bit of a nutcase, as you've probably already worked out. So in a small village, somewhere between Darlington and Stockton. And I prescribed those at that time, not because of the cardiovascular benefits or the fact they can lead to hospitalization reductions in a range of conditions, which we do know now. So a direct question to what does it do? Well, it keeps people out of hospital. Hospitals are horrible places because they're too busy. I'm old enough. One of the reasons I became interested in type 2 diabetes a long time ago, probably 30 years ago now, was simply because I knew it was going to double during my career, and it certainly has. So, and we can see that impact in poor aging. But by using these agents, such as SGLT2 inhibitors and GLP-1s and other drugs like finerenone, which doesn't lose weight, but or some of your other mineral cortical receptor antagonists, they keep people out of hospital. And we're talking about 20% reduction in hospitalization if you look across the board. But the reason I prescribed the SGLT2 inhibitors is because at the time, everything else, with the exception of metformin, caused weight gain. And it seemed a bit mean to all my patients. When I was telling them to lose weight, I gave them glucoside and pioglitazone, and they were getting bigger, or insulin, and they were getting bigger and bigger and bigger. And hardly an incentive to come and see me if I'm just going to make a problem I want them to fix worse.
In the interest of time, what I would say is if you want to hear more about these kind of things, I'm giving a talk at 2 p.m., I think, on CKM, cardiovascular, renal, metabolic medicine, so we'll cover a lot of these things.
Yeah, it'll be in the red stream, so I'm sharing it.
Great. And, please do, as I'm working through my questions here, please do put your questions onto Slido, and we'll take questions from the floor as well. But before I look at my phone to see if there are some Slido questions coming in, can you talk us through some of this pharmacological management, particularly with GLP-1s? What's happening with that? And are GPs changing their practice? And what's the impact so far? And what are the frustrations and pain points around the restrictions?
Well, it's interesting because pharmacological management of obesity was very limited up until not so long ago. We had orlistat, Seneca, and that was all essentially, and it was this standard diet and lifestyle, which are still important changes and things that we probably even now need to focus a little bit more on and more dedicated on, which sometimes it's tricky to. We had orlistat, then we had nothing, then we had the first of the incretin therapies which were available, which was liraglutide, and that was 3 milligrams, the higher dose rather than the 1.2 to 1.8 milligrams we used in diabetes, type 2 diabetes. And there was some reasonable evidence, but we're looking at that 5% weight loss. We're trying to get weight loss of 5%. And even then, with liraglutide, we weren't always confident in achieving that for a majority of people. But then over the last, 10 years now, we've had a raft of once-weekly injections for incretins. So we had semaglutide and dulaglutide for type 2 diabetes, which showed significant weight reductions with those medications in those with type 2 diabetes. And it's only natural to look at these molecules in those without diabetes and specifically without type 2. And this is where the obesity data for incretins came along, and we started with semaglutide, higher strength semaglutide, the 2.4 milligram doses or Wegovy. We've had tirzepatide, which is a dual GLP-1 and GIP agonist. And we've had variation. We've had oral semaglutide. We're going to have oral orforglipron, which is an oral GLP-1. We have triple agonists coming as well. We've heard data recently presented at the American Diabetes Association on retatrutide, GLP, GIP, and glucagon. These all work on our nutrient-stimulating hormones or our incretin effects. And they're quite robust weight loss from 15 all the way to 20 to 25% and 28% in Reta's case. So we're looking at, we've shifted the goalposts of weight loss with incretins and with medication now from that 5%, anything to be viable as a weight loss product to be 5% weight loss, to now it's the bare minimum. If we're getting anything at 5%, it's an inadequate medication now. We're looking at 10% at the very least to get there, to achieve that with these medications. So we've moved on. We've actually, technology and science has pushed the expectation of what weight loss we can achieve with medical therapy, and almost reaching bariatric standards with the retatrutide when it comes on.
Well, I think we are. I would argue it depends what sort of bariatric intervention. But if I'm old enough to remember when adjustable lap bands were a thing, they seem to be less popular these days. But because you have to adjust them, I think that's why patients have to come back. But we've now got drugs which are more effective, or at least as effective, in development. So an advanced development at that, and. Yeah, and in terms of what's happening in GP land, I suppose I mean, it's the most expensive drug, I think, now on in our budget is tirzepatide. So that was recently I read a headline, might have even been in MIMS, I don't know. But it's we do know that the numbers of prescribing of SGLT2 inhibitors and GLP-1s have doubled in the last 3 years. So clearly people are getting more confident in using those. Of course, if we're talking about using them specifically for weight loss, that's a much smaller number because obviously access is very limited at present. And remember, though, most of the people who consume incretins for weight loss are not getting it from a GP. They're getting it in the private sector, probably about 80-90%.
It's quite funny because I'm having to ask a lot of people when I see them in hospital as well, are they on weight loss medications privately, not just what's written on the GP record? I have to ask them specifically, and it's something that I've not had to do that often really in the past, and now it's almost commonplace. Or I've seen someone's HbA1cs or their weight has changed. I'm like, well, something must have happened, and a lot of the time it is that. So we it is driven by a lot of consumers' healthcare. I want to wonder is how many people here are prescribing incretins for weight loss, not for type 2 diabetes, for weight loss, as per the recommendations from NHS England about the BMI over 45, 40 and for health conditions. Yeah. And have you saturated your, like Pippin, for example, have you saturated the cohort for those tiers, or we've already done excellent. So how many more of the people, how many more are actually already on it who probably in the lower tiers of BMI over 30, less than 2 medical conditions? There's a huge number of that as well, and even more that would benefit. And this is the issue. Whilst prescription of incretins are recommended at certain BMI cutoffs and comorbidities, the realistic thing is we want to prevent them from getting that comorbidity. So actually we should open up to everyone. But how do we achieve that in primary care? I mean, in some places such as where I work, I'm embedded in primary care a bit more, so I can offer that support, but that's not available across the country, is there? And tier 3 services are limited, and there's over a year waiting list for tier 3 services in where I am.
I mean, when those hands came up, so we have those hands again, because I was surprised at that. So put your hands up if you are prescribing on the NHS rollout of tirzepatide, just because it's a small number. Now, I know Pip, he's from the northeast, so we had a rollout in the northeast, North Cumbria. Actually, it was the first in the country. So this huge variation. Do you know where the hotspot in the country is for? Apparently it's in East London. So there may be ethnic reasons for that, but the prescribing is huge, of particularly tirzepatide. Yeah, so there's politics, as I've said. There's also affordability, not only in terms of politics of who delivers that care. Can we afford it? We're already busy as GPs. How do we fit this in? My argument would be to use the same argument that I've used with my type 2 diabetes patients. It's better to get them when they're not so sick than when you get them very sick. Blood pressure management with advanced kidney disease is a nightmare, okay? It's a nightmare. But if you get it early and they don't develop the advanced kidney disease, it's a damn sight easier. You just give them 2 or 3 drugs. Once they start getting to a stage where, their feet blow up and you're having to use thiazide diuretics or drugs which bounce up their potassium, it starts becoming a nightmare. So I think managing people earlier is better, but can we afford it? Actually, as GPs are the right people? I don't know. But it's certainly, I would imagine, MedExpress would be delivering it a lot cheaper than we do, because they've developed models commercially. But whether they do as good a job as a good GP would do, I don't know.
Mm-hmm.
So I've seen a lot of the questions come up. I think it's good to get started on them because I've picked one ahead of you, so just because I've seen Orlistat.
Go for it.
I just wanted to mention. Someone mentioned, is there a role for Orlistat and what's the weight comparison? Well, Orlistat, if you're getting 5% weight loss in more than 60% of patients, we're lucky. It's not a great medication for weight loss. Incretins are way better. We'd use them. There is still maybe a role for it because people may not tolerate the GI side effects from incretins, and you can argue the GI side effects of Orlistat as well. But
and I think it raises an important issue. These are a bit like your dog. They're not just for Christmas, they're for life. It's like high blood pressure. You don't, when you get the patient down at 120/70, you don't go, stop your tablets. Well, if you do, the nurse will come into you screaming abdabs next time they're in and say, these blood pressure, the patients may stop the tablets, it's a separate thing. But with these things, if you stop, we know that weight gain comes back. It takes time, it may be 18 months, but it comes back. So Orlistat, the biggest challenge I've had, I've been prescribing Orlistat, I don't prescribe much of it now, but for a long time, patients do not stick with it. Every time they have a fish and chip dinner, as what we call up in the north, it's not good. It's not good. There is a particular side effect which is listed when they read the thing for this particular thing. And I know it's early in the morning, so I probably shouldn't even say it. But anal seepage. I don't think anybody really wants that, particularly not that morning. Anybody who had pastry this morning, it's all laced with Orlistat. So I think we need long-term solutions which are practical. Personally, I think a more effective medication, maybe these newer therapies which work on several targets at once are better. And they're not just stopping at 3. They're in development. There are quadruples, quintuple targets. It's mind-boggling.
I guess one more question. There's a few questions. I don't know if you work around. Is that easier or work down?
I'm seeing that the first 3 have been upvoted by the audience. So the first one is about, we're seeing dramatic weight reductions, but I'm concerned about the proportion of that being lean muscle tissue. In your clinic, are you formally prescribing resistance training or specific protein intake targets alongside tirzepatide? And how can primary care pragmatically monitor and mitigate this risk?
We've moved from kind of just weight loss to kind of where that weight loss is happening. And so lean muscle mass is always the concern. The risks of reducing muscle bulk, if you're losing weight, you're going to be losing, if you lose it predominantly from the key muscle groups where there's fat deposition, is it going to be impacting their functionality, called sarcopenia, etc. Now, there's 2 parts to this. One, it may be perhaps blown a bit out of proportion in your younger adults. And actually, if you look at fat deposition across anyone who's obese, there will be fat deposition adiposities in muscle tissue. So if you are losing weight, you're losing it symmetrically in areas where there's fat. So again, you will lose some muscle bulk because that's where some fat is. The adiposity is there. And that's ranged from, I guess, between 10 and 40%, depending on different trials you look at for GLP-1s. What the issue is, does it cause functional issues? Is it causing impact on mobility, impact on strength? And there's a trial, the SEMA-LEAN study, where they looked at that, and actually they found that it did not impact. In fact, it improved muscle function that weight loss. So actually, in younger adults and relatively healthy, if you can say that term, obese individuals, the impact of that perhaps is not as significant, but yes, there are certain things that we would talk about, and I'll come to that in a second. But in the older adults, and that's my area of interest, this is where we do look at a lot of that, it's that sarcopenic obesity subgroup. What does that mean? If we're losing weight, are we deconditioning people? Are we putting increased risk of them deconditioning, not mobilizing as well, risk of sarcopenia and reduce their mobility? And that is a real valid concern. I have a whole hour-long talk about that if you ever want that in the future. But I think there's a sarcopenic threshold. We're still learning about this. And I think older adults and use of incretins in older adults is not a significantly researched area, so it's difficult to say. Where there's a degree of weight loss and muscle impact that will cause below a sarcopenic threshold, which would then cause problems. This is what we need for the research to investigate, and it's something that we're looking at. And this is where newer molecules come in, where potentially can have muscle preservation, and there are other molecules that are added onto incretins that potentially could look at that. In terms of practical advice, especially in older adults who do start on incretins, and I have started as well, the general advice is the same. It's about the balance of healthy diet, and in people who are worried about sarcopenia and muscle loss, it's protein intake increase, and that's the key thing. So it's normally about 0.8 to 1.2 grams per kilogram per day, depending on where in the spectrum you want. If someone you think needs a bit more muscle strengthening, you've got a bit higher, so 1 to 1.2, whereas most people about 0.75 or 0.8 is fine. So that's the key thing, and actually it's funny how, people don't always have a lot of protein or don't use a lot of protein if you question the diet and look at the diet. So that's where dietary support comes in, and also asking them about what that means in practical elements. And the other thing is resistance training. That is important. I don't particularly prescribe that, but I do advise and give them examples of the resistance training. So weight resistance exercises, even aerobics and stuff is still useful. Any kind of exercise is beneficial, but especially the ones that focus on the key core muscle strengths, muscle groups.
Yeah, I mean, I would completely agree. I think the one thing I would highlight is often people don't think of malnutrition when managing people with obesity. The quality of the diet often is deficient in protein and other minerals. So I think we should learn a lot really from the bariatric medical community. So those guidelines which you have somewhere attached to someone's record, telling them to have this, that, and the other, I think we should be using the same guidance really until we've got more robust evidence, because we know that protects people. So not necessarily suggesting everybody goes on iron supplements, but I think we need to consider that, and we need to be checking to see what there are.
I suspect there's a lot of micronutrient reduction, which will make some of the side effects we see.
I think
I agree with that.
There is quite a bit of evidence of micronutrient deficiency in the general population. Even worse in some groups, so which often may have obesity. So I think, assessing from the outset, it's not just giving advice; it's actually trying to get an assessment, even if it's getting them to fill out a diary and try to calculate it themselves. And really, it's tough because I'm a GP. How much dietetic training did I have? Not much. Okay. I've had even less dietetic training than I had on dressings, and that was non-existent either. So I think we do need to lean on others within the team to deliver those sorts of things. But yeah, I think consider nutrition in general, I think, is super important. One question which is associated with this, which I want just to ask you, Amar. So often the question people ask me is, what level of frailty, if someone's got type 2 diabetes, so we're not treating obesity here, so we're jumping a little bit, but would you consider GLP-1? Or would you rather, which you would say definitely not?
So it's interesting. I think severe frailty is where I'd probably limit it, probably more like to go in with a mindset saying no rather than yes in the mind. There'll be very few people in that cohort. There's some caveats that I would consider, because that group would have certain other issues, and there's not much evidence on benefit in terms of what are we trying to achieve. If we're looking at weight loss, what's the benefit? Is the functional benefit? What's the benefit in that group? We don't know, and the complications and the side effect profiles again might be at risk as well. In the moderate mild severity frailty, that's fine. In the moderate frailty, I'm certainly prescribed a lot more of it over the last year. I've been more conscious of it, and speaking to someone who in the past was talking about de-intensification, de-prescribing, I've gone to a stage where actually let's look at this a bit more focused and see what are we trying to achieve, what's the benefit. I think I do a lot of cardiometabolic MDTs, which we'll talk about in my other talk, but looking at actually the 2 prescriptions in this cohort, and I'm starting to look at it more and more with incretins as well. And I would say moderate frailty is not a contraindication, not something, and I actively would look at it as any other medication consideration in this group for the right reasons.
And again, just being very specific, so I tend to use the Rockwood scale, so there's the clinical frailty score thing, because I've got an app, and it's dead easy to do because it's just questions. But what tools as GPs can we use to assess what's mild, moderate, severe?
EFI.
Accurately.
EFI. EFI, okay, accurate, fine. EFI is a good screening tool. So electronic frailty index is probably the best one to start off with. 0.3 or 0.45, the cutoff. So 0.34, that's the 0.34. So I would use the electronic index to then further assess the person. I like Rockwood. I use that in practice. There's a few others like mid-frail and a few other assessments, SARC-C, but I would just stick with this too simple EFI. Keep it simple. Don't make it too complex. And what you think, what you look at.
It's free on Apple and Google, and I have no shares in the company which produce it.
Whoever asked the next question, I appreciate.
Can I just read out the question, if that's all right? So this one is the top upvoted question, and just for your information, we've only got 5 minutes left now because our clock is not telling us. Yep. So what's your advice on how we can support people when they stop the weight loss injections in avoiding gaining the weight back? I think that's a really key question.
Okay. Well, I mean, I think we've sort of covered it a little bit. It's dog is for life, not for Christmas. These drugs are for life, not Christmas. So that's the first thing. Often patients do want to reduce the medication, but weight gain is likely to go up. What things can lead to additional weight gain and actually optimize their weight gain? Probably exercise, obviously nutritional advice, but they're probably aware of that. But yeah, physical exercise improves the efficacy of these drugs.
In terms of absolute evidence, we don't have anything that besides the ongoing lifestyle and dietary change, nothing maintains that weight loss once you're off the incretin therapy. Is get weight regain. Everything's shown that so far. The people who had a healthy diet and lifestyle, the weight gain maybe is slower, but it's still regain. That's the key thing. So this is where we're looking at things like oral molecules that may come and may help support that. Do we look at pulsed? And there was some data, some people looking at alternate week Manjaro or tirzepatide maintained weight in some people. There's some data that was presented before and published. But I think we're looking at, that's the next stage, weight maintenance, and there's different ways people are looking at that. And that's where the Maintain trial looked at oral molecules. But again, these are still tablets and medications. There's nothing that stops that weight regain.
The next question there, if type 2 diabetes patient, says this is not an uncommon scenario.
Whoever asked this question, I've been agonizing over this very thing for a long time.
I think it's relatively
let me just read it out so everyone knows. So if a type 2 diabetes patient on tirzepatide normalizes their HbA1c but is still obese, should we stop the drug or continue it even if they don't meet the current NHS obesity rollout criteria?
Think about it, the kind of other sides of the argument.
Well, they've got diabetes, haven't they? So you've diagnosed it, so that's the answer. They've still got diabetes. Until someone tells us there's a new criteria, including remission for people on...
But there is remission criteria, though.
There is.
How do we know someone's not in remission if we don't stop a medication?
Okay. So the person-centric answer to this is I ask the patient. So usually these people are on a whole bunch of pills. And I usually say, which one do you want to lose? And I say, I don't want you to stop your statin. I don't want you to stop your SGLT2 inhibitor. But your metformin, do you want to come off that? Or your tirzepatide? And they usually want to stay on the tirzepatide. I might reduce the dose down. But and again, thinking what the main target is. So the patient weight might be their more important target because they see it, they feel it, rather than the HbA1c. But I certainly, if it's the one thing that worked, it seems foolish to stop it. That would be my view. And remember, guidelines are not tramlines. Clinicians ultimately make decisions. That's what NICE says. So you just need to document, because it helps colleagues in future, document why the decision was made and what the follow-up process is.
The argument is we know weight regain occurs if you stop these medications. We know weight regain and weight deposition is also going to increase the risk of type 2 diabetes again and bring that back up. So why are you doing something that you know is going to cause increasing their risk and for them to have diabetes recurrence, basically? So maintenance therapy is the main thing. And the key thing is they're still obese, so they still have risk factors. They're still at risk of, they're still not fully treated, so to speak. So that's the simple answer. If you can say that.
And also, if we said semaglutide, because tirzepatide is slightly more controversial, but if we said semaglutide, we know that reduces cardiovascular disease in people with high-risk type 2 diabetes for cardiovascular disease. We know cardiovascular disease remains one of the leading causes of death in people with type 2 diabetes. So we don't tell people to stop the statin. We don't tell people to stop their SGLT2 inhibitor. Why? Because outcomes are worse in those people who stop it. So that's...
When it's off patent, we're good. Is that what you're saying?
I'm probably why I left general practice, but I'm not bothered about the money. I'm bothered about the patient. So I think, actually all of us are. So I think, no, you do your best for the person in front of you. I think if it's worked in that patient, that would be the last thing. If it's not the thing that worked and it just reduced their weight, I think that's a different issue. But if they've got type 2 diabetes and you've started it appropriately within the pathways, then they're not in the obesity cohort. That would be my view. Amar's right to say we could say they're in remission, but they need to be off the medication for a period of time, during which they're putting weight on, and it becomes, what we're trying to achieve, health, one would hope.
Yeah.
So
I'm sorry to say we're out of time. We could have easily carried on for quite a lot longer, and thank you so much to everybody for all your questions, which are really fantastic. And can I suggest that since both Patrick and Amar are here for a large proportion of the day, that do just come and chat to them. If you've got questions that you would like answered, then they're here. So have a one-to-one conversation.
Not too many questions on Otto von Bismarck.
And Amar is speaking about CVRM.
We'll touch a bit of the things that have been mentioned there as well. We can even talk a bit more about it there as well.
So you'll be picking up themes, and Patrick is kindly sharing a stream. So it's been absolutely great to have them on the panel. Thank you so much. Thank you.
Thanks,
Some thought-provoking insights and glimpses into the future there, I feel. And we'll continue to provide learning around obesity over the next few months as part of our Confidence in Obesity Care campaign. Thanks very much to Dr. Holmes and Dr. Puttanna for taking part in this discussion, and thank you for listening. Don't forget you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. Thanks for listening. We've been the MIMS Learning editorial team, and this episode was produced by Jude Owen. We'll see you next time.